For the July edition of Coffee with Coker. As always, it's a privilege to have you join us. Immediately following today's presentation, we will have a question and answer period, so please feel free to submit your questions throughout the presentation in the area provided in the GoToMeeting dashboard. The participant phone line will be muted for today's presentation, and the materials will be emailed to you tomorrow. As you exit the webinar, a brief survey will pop up, and we would greatly appreciate your feedback on this presentation as well as suggestions for future topics. Jeff Gorky, Senior Vice President at Coker Group, will be leading today's presentation. Please join me in welcoming Jeff.
Thank you, Savannah, and thanks to everybody who is carving time out of their busy day or busy day to listen to me chat for a little bit this afternoon. I wanted to emphasize something that Savannah had just said, which is we really do value your feedback, and any feedback that you have to offer would be beneficial because, you know, given the nature of what we do, the nature of the topic, and the differing roles of the job roles of the attendees, we want to make sure that we tailor things to what you all need. And so today's topic is changes here, how value-based initiatives will impact medical practices. And I will start off with a caveat that says to you basically, if you are looking for the magic bullet or the holy grail of payment moving forward, this won't be the time or the place for that. And I would suggest to you that anyone who says that they have that magic bullet may be a little bit off of center, at least right now, because a lot of what is going on in the value-based area is really still in flux, primarily based on the topic we'll talk about a little bit today is MACRA, MIPS, and all that good stuff that is in comment period right now, with the final rule expected in early November. So with that, with those caveats, again, your feedback would be welcome, and I'd love to hear from you, regardless of how that feedback goes. Obviously, better would be nice, but we'll see how it goes from here. What we're going to do today, apropos of value-based care and the delivery of value-based care, is really discuss how the new models and methodologies are going to impact the finances of the practices. We'll examine MACRA and MIPS broadly, why we're here, a little bit of history relative to that. For those of you who haven't grown up in healthcare over the last 30 years, that may be nice to hear some of the background. And for those of you who have been in healthcare as long as I have, it might be an interesting refresher. We'll review the financial aspects of MIPS as they are currently laid out. We'll contemplate how administrators can manage MIPS into the delivery of care. And practice administrators, whether you're an employed practice or private practice, will play a role in how this moves forward, and we'll delve into that a little bit deeper during the call today. We're going to examine how the care process design can help practices ensure profitability under new reimbursement models. And what I'm endeavoring to do in the discussion today is, I think we've all heard and read a lot about MACRA and MIPS, and what I tend to do in these presentations is I'd like to try to boil it down into simple math. It's a lot easier for me to understand, and I think it's easier for me to present that way. And so we'll look at some aspects of MACRA MIPS, and then look at using just some broad numbers, real simplistic examples, how administrators or anyone running a medical practice will be able to impact change under MACRA MIPS and benefit or be harmed by the legislation as it's been presented so far. And then vis-a-vis care processes, we'll consider how to prepare for MACRA and MIPS, and we'll go through, again, some examples using really facile numbers that I hope really more than anything paint sort of a practical picture of how the math might work within the practice. One thing we will not do today, though, is I will not tell you how bundled payments are going to flow through your practice, or how that reimbursement methodology is going to work, because as of right now, relative to MACRA MIPS, some of that still remains to be seen. The Medicare Access and CHIP Reauthorization Act, MACRA, where we are now and what we know. So as a little bit of a precursor to the MACRA MIPS thing, I have been around since the RVU rollout in the early 90s, late 80s, early 90s, and what we've seen over the course of time, the various iterations on how physicians will be paid, whether it's Part A or Part B, and Medicare's kind of plodding along the way to figure that out. And when things get a little expensive, which they can do, there'll be a change or an adjustment, and that's what we're going through right now. So you went from essentially and broadly the deployment of the RBRVS and the Medicare fee schedule over a period of time in the late 80s, early 90s, and then as expenses started to creep up to the Medicare program, Medicare developed a sustainable growth rate. For those of you who have been in this business since the 90s, you're all too familiar with the annual threat of a reduction in reimbursement to physicians. We would go through that every year where Congress would pass, or excuse me, CMS would put out the proposed reductions in fees to physicians, and then all the specialty societies, rightfully so in many instances, would get up in arms about the impending reductions. Congress would step in at the 11th hour and essentially put back burner the SGR changes for the year. And this was an ongoing year after year process that really, if anyone knows anything in detail about the SGR, and I won't get into it in too much detail, if you work through the math on that, it's a pretty crazy kind of scheme. And in any event, I'll just leave it at that. And so MACRA and MIPS have really been put into play to get us past the craziness of the sustainable growth rate model, and they're looking now not only at the cost of delivery of care, but MACRA really takes into account the delivery of care and quality outcomes. And so MACRA was passed in 2015. The notice of proposed rulemaking was issued in April of this year, and that was followed by a torrent of kind of opinion-related pieces relative to what that thing looked like. The final rule is expected in November 2016, as most of the final rules are. And there are rumors now that the implementation of MACRA may be pushed. Several societies have chimed in, including American Medical Association, American Academy of Family Practitioners, and the MGMA, to name just a few. And they're looking to delay the implementation, and we'll get into the implementation timelines and dates a little bit later. Recent article I saw by the AAFP is they were pushing for no earlier than mid-July, or excuse me, mid-year next year, 2017, with a preference of pushing deployment of MACRA out into 1/1/2018. What I understand as of this week, there is a sense that CMS may delay this a little bit. And I will tell you candidly, in reviewing it, and if you have difficulty sleeping one day, you can pull out the proposed rule and read through that in detail. But the bottom line is that the thing is gangly, and trying to implement it by January 1st will be a little bit of a challenge. So we'll talk a little bit more about that as we move through the discussion today. As I said, MACRA replaces the SGR, but this time it's not just a cost issue that the government is looking to get into. It's also the improvement of quality, and I think we can all agree that that's one of the things that as healthcare has moved along, physicians have been compensated, and we've been kind of geared up relative to episodic treatment of disease states. And so we've been managing things without, and I'm not saying delivering bad care, but what I am saying is you may have a patient that's on an ongoing 6-month recheck cycle for whatever their condition may be. And instead of fixing it, quote unquote, we tend to manage the patient and move them along through the system. And so it's a very laudable idea, obviously, to improve quality and improve patient outcomes while reducing cost. The question is, are those two mutually exclusive? They probably are not, but it will definitely take efforts, especially by management teams, to manage the cost aspect of this while we work with our physicians and our providers to improve quality. MACRA consolidates a bunch of reporting payment incentives that are already out there. So PQRS, which everyone has had exposure to for several years, the value payment modifier, and meaningful use, which everyone has bumped into again for the last few years. It includes, MACRA includes Medicare Incentive Payment System and alternative payment models, which we'll get into a little bit later. But those are, as some of these other methodologies have been historically, a little bit of carrot and a little bit of stick. And we'll talk about that as we move forward. The overarching goals of CMS in rolling out MACRA is that physician payments will be tied to value through alternative payment methodologies, 30% of physician payments by the end of 2016 and 50% by the end of 2018. And so if you think about the Medicare, and this is where I get a little jaundiced relative to the deployment date of 1/1. If you look at Medicare as it is currently with regard to physicians, it just seems to me that in the next few months, deploying this and moving forward is going to be a little bit unwieldy. So thus my thought that MIPS may be pushed off a little bit further. But total Medicare payments, the initial goal is tied to quality or value, 85% by the end of 16, 90% by the end of 2018. So for those of you in private practice, you can think about what this is going to mean to how you deliver care, especially as it pertains to your physicians, their productivity, their schedules, and your IT backbone and infrastructure. So MIPS as a part of MACRA. MIPS will begin January 2019. The rewards for performance are going to have a 2-year look back. And so when we talk about the 2017 rollout, that's what we're referring to. So the measurement period, at least as it's contemplated in the CFR by the proposed rule, is that in 2017, they're going to start looking at what providers are doing for payment in 2019. The eligible participants in the Medicare Incentive Payment System are physicians, dentists, PAs and NPs, clinical nurse specialists, and CRNAs. In year 3, and I'm not sure why this is, but I'm just going to tell you what I have and the information I have. In year 3, looking at rehab pros such as PTs, OTs, speech and language pathologies and therapists, audiology, nurse midwives, social workers, clinical psych, dietitianists, and nutritional professionals. The ineligible providers, and it stands to reason, are going to be first-year providers with Medicare Part B, those providers who bill less than $10,000 a year in Medicare, those providers who care for 100 or fewer Medicare patients, those who already are participating in some form of advanced practice methodologies, and hospitals. So how this is going to work, and this is where we get into a little bit of the payment scheme relative to provider reimbursement. You have 50% of the reporting and quality, PQRS, resource use, which is going to be your cost to deliver care, clinical practice improvement, 15%, and advancing care information. And so what is going to happen is in year 1, those are the numbers that I just read to you. You'll have 50% on quality, 10% on resource, 15% on practice improvement activities, and 25% in advancing care information. Year 2, you can see how those have adjusted. Quality will drop down to approximately 30%. Resource use, so cost, will go up to 30%. The CPIA will stay at 15%, and advancing care information will stay at 25%. And so what I've done here, and I'll go back just a second, here are basically the 4 composite scoring pieces that will be out there. And what I've done here is broken down quality so that you can look at what that means precisely. So when we look at quality, the measures that are going to be forward are PHI protection, e-prescribing, patient electronic access, coordination of care via patient engagement, health information exchange, public health and clinical data reporting, and then 3 population health-based measurements. And so if you run a practice or you're running a practice, you start to get a sense based on the MIPS piece here, how the topics that you actually could play a role in, but also some of the things that you really already should be doing. Now, I won't get into the detail of PHI. I think some of that still needs to be fleshed out. But certainly in your practices on a day-to-day basis, there should be PHI protections already in place. E-prescribing probably should already be taking place. Patient electronic access is a little more prickly, but again, there's no reason why that shouldn't already be rolled out in many practices across the country. I will tell you, just by way of discussion, I'm a recovering practice administrator and haven't done it in a long time, but we put an EMR in many years ago, and we were able to provide patients with access to the records, boy, it was 16 years ago. So it's doable. It's just a question of effort, and unfortunately that's where it's going to come down to management resources and expanding the limited bandwidth that the managers of the clinics have in place. Coordination of care via patient engagement, again, that's going to be how in touch with the patient with regard to their health records. And as you go through these topics, you can kind of get a sense of what the direction is, right? We obviously, as we move forward in healthcare, want the patients to be engaged. We want the patients to help manage their care. Now, whether they do that or not is a different story altogether. But this is all an effort to make things transparent for patients and let them help participate in the management of the care. The health information exchange, obviously that's going to require connectivity. It's going to require at least moderately robust healthcare IT infrastructure. And if you're an integrated network, like a clinically integrated network, you either already have that or you've got multiple systems that ride on one backbone that have to talk to each other. And so these are the things that are going to be pushed forth, are how do we work on quality with connectivity and interactivity. And for those of you who have been in healthcare since at least the mid-2000s, you know there's great discussion about health information exchanges, whether nationally or regionally or whatever the case may be. And I have to tell you that the cynic in me looked at that and said, that sounds awesome, but the pragmatist in me looked at that and thought, how are you going to tie all these multitude of systems together and get them to talk transparently? And so that's one of the struggles that we're going to have as this evolves. And then the public health and clinical data reporting, of course, is going to revolve around collecting outcomes data relative to patients that will probably be stratified and all that good stuff as people start looking through that data and managing the data. And then resource cost, this is an area where I think that the administrator, the management teams can play a role. And as you can see, as it becomes 30% of the deliverable on MIPS, that's going to play a fairly huge role. And then clinical practice improvement activities, we'll get into that a little bit more, and advancing care information. Again, that's all about data transparency, information sharing, and quality outcomes reporting. And so why does this matter? Obviously, payments, CMS intends to set the payment threshold so that 50% of eligible clinicians will receive a favorable adjustment and 50% will receive a negative adjustment. So the goal will be to remain budget neutral. Now, the interesting piece to this, though, the caveat is they're going to have an extra 10% upward mobility in payments for quote-unquote exceptional performance, and that'll be outside of the budget neutral component. So for those of you from sustainable growth rate days, you understand the key is trying to keep the budget neutral, not increase cost to the system, and that for me is what is going to be the struggle for Medicare. Now, the flip side of that is, if they are able to do that with some veracity, the struggle then becomes, how is that going to impact the physicians? I mean, who amongst you with your physicians, whether you're in a 10-doc practice or a 100-doc or 500-doc practice, how are you going to become exceptional performance, and how are you going to ensure that you are not in that negative, that 50% with a negative adjustment? And so right now, as the process and the system is contemplated, payments are going to be adjusted as I've delineated below, where Medicare is going to be, I'll say, sort of nice to you as you move forward in 2019. So as they look at your 27 information, you're going to be up for a plus or minus 4% adjustment. As they get to 2020, you can see it's plus or minus 5, 2021 plus or minus 7, 2022 plus or minus 9, and then they've also thrown this, there may be an adjustment by a factor of 3 to maintain budget neutrality. So to my earlier point at the beginning of the discussion, you can see that there are a lot of moving parts to this, and it would be a fool's errand to suggest that I could tell you right now exactly how you're going to get paid. But I can tell you how to prepare for this. So MIPS providers that are in an APM, Advanced Payment Methodology setup right now, may receive an additional increase in reimbursement of 0.5% until 2020. So as I go through this, I'm going to try to, as I said, these are sort of absurd but round numbers to show you what we're talking about. If you're in a practice that's doing $1 million in Part B Medicare revenue, obviously if you don't meet the threshold in 2019 or for 2019 payout, you're going to be dinged by $40,000. If you do max the threshold, you'll pick up 40 grand, and so that logic flows throughout. In 2020, the 5%, 2021, the 7%, and then 2022, the 9%. And as you can see, if you don't prepare for it and you don't start to get ready for it, things can get kind of ugly over the course of the next 4 or 5 years. So take that example, the $1 million example, and just say you're doing $10 million a year in Medicare revenue. Well, again, you can see those numbers, same percent thresholds, high and low apply, but you can see the difference that makes in 2022 if you hit the low threshold. And so where you otherwise might have expected $10 million in Part B payments, you're down to 9.1. And if you're in a private practice, that's $900,000 that doesn't drop to the bottom line. So you can see how this will impact private practices. And part of what's going to happen, obviously, at least in the near term, is this is Medicare specific. However, I can guarantee you the commercial payers are going to watch and learn and listen to what's going on, and they're already developing many of their own models. And so what I envision happening is if you're in a if you're in a Medicare B heavy patient-based demographic, so if you're in cardiology and you've got 40 to 50% of your patients who are Medicare patients or Advantage patients, you can see the impact that this may have. If you're in a specialty where you're really low on your Medicare patients, maybe not as big a deal, but certainly one that you need to get your arms wrapped around, because the idea of global delivery of a patient's care is well on its way. And so the days of just sort of ducking while Medicare adjustments impact high Medicare specialties are probably fallen by the wayside. So advanced alternative payment models fall under MACRA. These are the current APMs that are out there are those things, those setups that CMS has with regard to, say, CMS Innovation Center models, like patient medical home model, shared savings programs, demonstration under health quality demo programs, demonstrations that are required by federal law like CJR. The advanced models, to be enrolled in an advanced model, you need a certified EMR. Base payments on quality measures have to be comparable to the MIPS in quality category. You have to have at least one outcome measure. And participants need to, I don't want to say need to, participants have a nominal financial risk. And as you note in the last bullet, the expected advanced APMs in 2017, MSSP tracks 2 and 3 next generation ACO models, etc. You can read those there. In 2021, CMS will consider other payer APM models. So you can see the healthcare payer network, if you will, is going to start to look back and forth between commercial and public. What are the best models out there, and what can we use to advance the ideas of improved patient care and lower cost? So by 2021, it's expected CMS will potentially recognize other APMs that are established by other payers, if they're a better mousetrap. And again, you'll need to use certified EHR, required quality metrics will be in play, and then some financial risk in medical home. And there is the possibility of a bonus payment for qualified providers and advanced APMs. So now we get into the idea of how we're going to handle that potential reimbursement conundrum. And one of the things we wanted to look at, or that I wanted to look at, and I hope you do too, is is clinical integration and what that means to where we are or where we're going. So even if you're in a private practice right now, I would suggest you have a level of clinical integration. It may be scattered, and it may be as simple as, sending information, electronically submitting information to a referring provider, or vice versa, or sharing images. So you're on some level of integration, if you will. But definitionally, I would suggest to you that obviously clinical integration is where we're sharing very fluidly patient information back and forth within a defined network of providers, whether they're in an affiliated group together or individual providers. I mean, you could be in, let's just say, the greater Atlanta area, where you have 800 providers on different systems, but they are able to integrate together to share patient care information. Many of the provider groups are now functioning as patient-centered medical homes, have participated in CPC and CPC Plus programs. The clinical integration structures, rather historically, contain activities to drive volume. So this is where sort of the old, if you will, the old structure organizations will match, they'll align for volume delivery, but they may not align for these value-based payment methodologies, if you will. So in other words, if I've got an internal medicine doc, we're on a clinically integrated network, we negotiate fees together and all this stuff, and we're able to share information back and forth. I refer out to my cardiologist, someone who has a flutter, or whatever the case may be, or I think it's CHF. So I refer them out. Let's go a different step. Let's go that it's someone who suspect need for an intervention or diagnostic cardiovascular study. So I send them to the cardiologist. He then does a diagnostic. He then inserts a stent. Prior to that, maybe he did an echo and a nuke study on the patient, and then turfs back the results, but also manage that patient's care on an ongoing basis. And so the question is, what is the quality outcome of that? And have we just exploded the episodic piece there? And I am not a clinician, I'm telling you that. But looking in at the data, it's, have we, blown up the episodic delivery of care versus trying to manage that condition back into a quality outcome where the patient is managed out of the house, and we do telemedicine, or we deploy some other thing where we can reduce the cost of the system, maintain that high level quality of care, and oh, by the way, if we have the opportunity to fix the person, to see them annually versus every 6 months, is that attainable? So that was the longer version of, do clinically integrated models necessarily align to deliver less episodic care and quality outcomes? I would suggest to you that presently they might not. And so care delivery systems are going to need to retool, kind of restructure where they are to produce the high value care to compete in the value-based reimbursement schemes that are on their way. And so, as I said, clinical integration does not necessarily dictate improved quality and or process change. It may be just a volume shift. And so these networks that are set up, I think, are in a good, sound position to move forward to start to coordinate better delivery of care. And understand, I'm not suggesting that they aren't necessarily, but I'm suggesting that maybe they don't provide the best avenue in the current situation to deliver the highest value care at the lowest cost. And so you see my little elephant thing, my little graphic at the bottom. For me, clinical integration and care process design really revolves around taking one bite at a time. So you might bite the elephant in the chest there over the front legs and get into E&M visits, or an E&M visit, or you might jump into hip surgery if you're in an ortho practice or something like that, to understand what we're doing in our care process to manage cost and to maximize quality outcomes. And I would suggest to you that to make this process happen, it's going to require you to hug a physician. Maybe not literally, but we really need to partner with providers to not only understand better where they're coming from, but we need physician and extender, advanced practice professional, we need buy-in from them to move this forward. And they need to understand very clearly what the end game is, because they're scientists, they get it when you explain it to them. If you're like me and you can look at a pretty picture and understand better what's going on, more power to you. But we need to engage physicians to move this forward. So you eat the elephant in one bite at a time. So to that end, my suggestion is look at the macro, not the micro. Don't get overwhelmed by all the little pieces, but instead pick a piece. Pick one process, put together a multidisciplinary team, and you need a clinical contingent, whatever that looks like, and you need relevant staff to each step in the process, because what this is going to entail is a fairly strict adherence to cost reduction. And so when you identify what that thing is, whether it's the better outcomes and better process and procedure of a total knee, or how are we reviewing how are we accommodating a patient who's coming in for an E&M visit, how do we improve that process to make it more efficient? And I'll get into that again with some of my simple math down the road. So it's time, it's quantify, evaluate, value, revisit, refine. And once you've done that, you can kind of back burner that one for future TLC and adjustment and refinement over a period. Then you choose your next protocol and repeat the process. And you can impact many of the components from a management perspective, because I feel that, from having lived and breathed in the trenches, doing enough of the clinical side up to the point that I could, which is understanding the specialties with which I worked, so that I could offer some lucid, cogent thoughts relative to delivery of care. Understanding the pieces where the operational team plays a role. And by operational team, I would say that the clinical staff kind of walks that line of operations, because they are going to help make things more efficient within the clinic setting. All of that said, and putting aside my thoughts that are just Jeff's thoughts at this time, but putting aside my thoughts that this won't be unveiled 1/1/2017, I think there's no better time than the present to begin on this process, because if we don't set a timeline for this, at least moving forward, when the thing unveils, we're going to get run over. And I will tell you, it will come in some way, shape, or form, and you will get a stick and not just a carrot. And so we've really got to prepare ourselves, and I'd say document it, write it down, because those things that we kind of leave on the side and noodle around, and we don't kind of commit them to an approach, a team approach, and moving forward, they usually are the things that we don't tend to. So I think there's no better time than the present to contemplate and define some timelines and get a physician or a physician advisory committee, depending on the size of your group, to move forward and start to work on this process. And so, again, as I said, here are the MIPS measures that are coming down the road. And the question becomes, how can you impact these items? What areas can we as non-clinicians play a role in helping to improve quality of care and decrease cost? And some of you may be administrators or leaders in the management side of the business who have clinical backgrounds, and that's even better. For me, again, I know enough about clinic operations and the delivery of care to be dangerous, and that's when I punt to the people who are much smarter than me on the physician and NP and PA side to help get things done. So in terms of the things that you can impact, this is the slide. I've actually parsed it down just to get back to those components on the quality side, right? So the areas for MIPS are going to be quality, resource use, CPIA, and ACI. And as you look through this list, and as I noted earlier, we could see areas where we can, as the management team and the operators, impact some of these things. PHI, for instance, patient electronic access, we can facilitate that aspect. Coordination of care, I think, is apropos of patient engagement and access and facilitating that. Health information exchange, ditto. The problem that I see with that, glad it's, at least right now, the max points are fairly nominal, relatively speaking. The problem with that is the funding for health information exchange, the IT backbone, and things of that nature. I was actually talking to a client yesterday, and they feel like their data, they're totally, at least this is what they feel like right now, they are totally lined up with the data they're collecting, grabbing, and gathering. The problem for them is, as this unveils and unrolls, are they going to have the intellectual capacity and human capital bandwidth in the IT side to manage all this stuff? And they're just not sure that's going to be available yet. And as we all know, with respect to all of our IT friends who might be on the line, generally speaking, as much as I like information technology and how it applies to healthcare and the great benefits and uses of it, it's usually a sunk cost into the structure. And I know better than that, but I will tell you I know a fair number of CIOs who cringe every time you ask them to buy another tablet or get some sort of interface or do whatever else, even though that's going to help towards this end. So and my sense is that the IT coordination and backbone and those numbers as they evolve are going to be a little bit of a struggle. And again, that's one of the reasons for me that I don't know that this is fully fleshed out for the 1st of January. So what can you unpack from the quality side, the things that I had alluded to? Patient electronic access, PHI, related things, which is operational and structural, the coordination of care, and be an advocate and adjunct to these items. Again, I know most of us are not experts in all of these areas, but we are going to need to, on the operational side, facilitate how this moves forward. And we're going to need to be the cheerleaders on this. And for those of you in the trenches, it's another thing to add to your plate. I get it, but it is something that is going to impact you, especially as you move down the road. Whether or not you're impacted in a large way by Medicare, these things are on their way as we move forward in the near future. Here's one of the aspects that operational we can certainly work on, and it's resource used or defined cost. Get into, no, I'm moving ahead. So we can impact the cost of the delivery of care, and I should have a couple slides in here that paint for you a picture of what that looks like with some simple math and ideas that I think are tenable and easily deployed relative to where we are as we move forward and restructuring how we deliver care. So optimizing effectiveness, efficiency, and current care process. Better understanding of care processes is the first step. And so that's, again, evaluating how you deliver the services you deliver in your practices. And as I said earlier, looking at those on the whole, just trying to understand and pick apart a thing is probably better than looking at all of the multitude of things that you do to deliver care on a daily basis. And so what I would suggest is the mapping of techniques, utilizing the latest innovations in process management systems. Pay particular attention identifying and eliminating artificial variability in patient flow when you look at this from a clinical perspective. And the designing new processes of care. So providers may have to design new processes of care to meet the challenges of achieving how well the now accepted triple aim in healthcare. So inputs of providers will be key, and the partnering is going to be essential. The design teams have to recognize that care delivery doesn't occur within the four walls of the traditional healthcare facility. And so as we expand these things and we try to manage the cost in the brick and mortar delivery or the readmission delivery, if you're working hand in hand with a hospital in your integrated network, is how do we keep those patients out of the, and legitimately, obviously, you're not going to keep them out to keep them out, but how do we manage care remotely, via pharmacy possibly, and remote monitoring of patient care with an assigned RN, or telemedicine, or phone consults, or even group meetings, or going out face-to-face with meetings, excuse me. And so here are some of my numbers relative to, again, trying to bake down the narrative into something I hope is beneficial to you. It's certainly beneficial to me, so I'm going to go with it. So here's my absurd but useful, I hope, example. So as you look at a clinic or a function throughout a clinical organization, and this is not relegated to a single clinic. It could be done, I would suggest you, on a clinically integrated model if you've got multiple different practices involved, but they handle a specialty. Let's just say the management of if, for lack of a better thing, we'll go with knee or hip replacement, just because those are high dollar, high variability, and so you could still manage them throughout a clinically integrated network. But what this requires is we're going to look at procedure X to review. And as we looked at review, we determined that staffing and the other cost pieces for delivery of each procedure X are $113. So if you look at my little absurd model, you see staffing is 38, supplies are 25, IT and other stuff is 50. And obviously you'd need to boil down those pieces and understand those cost drivers relative to procedure X. So we've actually kind of fast forwarded. And what we're assuming is that you're able to boil those down. And honestly, as I looked at this, I really looked at this as an E&M visit, and I'm looking at this as a practice that's got too much nurse time, no process in place, and they're involving way too much cost in the delivery of the procedure. So we're going to say procedure X takes 45 minutes to perform. And given the inputs and variables, you can see that you can only do 9.3 a day. And let's say the reimbursement, if you look below at the model, reimbursement's $150. So the maximum reimbursement you could expect on a basic, fee-for-service delivery is $1,400. So the cost per visit is $113. You're making roughly 25% margin on that. And so that's not to give you any inclination as to how to better manage a fee-for-service, but what we're trying to get to here is how do we manage our cost side of the equation so that we can increase access, which is going to be important still, and decrease the cost by removing variability and delivering higher quality repeatable outcomes. So if we call procedure X my total hips, and I know the number's a little wacky for a total hip, and we'll just say, whatever heavy, no process, the per visit is X, you can see how that starts to play out. We've limited our access because it takes us too much time, and our reimbursements are only slightly keeping ahead of pace of our cost. So what we did is our awesome administrative team or physician advisory team in the mixed group, what they did is they came up with a careful review of procedure X. And they did some time-driven, activity-based accounting studies. They were able to reduce cost, better utilizing staff to their fullest scope of practice. They, after reviewing, reduced the use of supplies or choosing 12 different hip replacement thingies, and they winnowed that down to maybe 3, and they were able to get all the physicians to buy into that. And then they better manage their IT buy or more efficiently use their IT. Now, again, I know I'm throwing this out there in kind of generalities, but nonetheless, I'm trying to point to the role and the opportunity for folks on the operational side to help manage down the cost and help drive quality care. So in this scenario, we managed to drive staffing down to $30 for each procedure, supplies down to 22, and IT nominally down to 48. So we came out with a cost per procedure X of $100. And while we were doing that, we managed to bake in increased access because we flattened out our variability in the delivery, and we got more access. So again, purely on a fee-for-service look, we were now able to generate 14 visits, same reimbursement, but more capacity for $2,100 in reimbursement. We've lowered our costs for delivery, and we've increased our margins. So what we've done on the whole is, as you can see, just side by side, cost per visit went down $13, margin per visit went up 8%, patient volume went up 4.6 patients, almost 5 patients. I'm not sure where the 0.6 would be, but they're there. And then revenue, obviously, we were able to expand the revenue $700 for that day. So again, more than anything, this is a simple exercise in showing, I hope, how it's going to be essential for the operators out there to help work with their clinicians in flattening out the cost side of the delivery of care. And again, the idea is going to be engagement, because there's no way that the administrative teams are going to be able to deploy these things and do these things without full engagement of the providers and without full buy-in of the providers. It's just not going to happen, but it needs to happen. So the outcome here, ideally, repeatable outcomes. We've now, gotten our adjusted rate down on our total hips, the quality, the outpatient stuff, all that stuff's good. Higher quality delivery of care. Boom. Staff utilized more effectively and to the full scope of their respective clinical roles. Better management utilization of our IT systems, better utilization of purchasing of supplies, reduce the time of procedure X, and increase the maximum patient load. And the thing that I mentioned earlier, we'll need to hire, need to be or hire data analysts so that we can track, measure, monitor, and adjust. Because we are going to need data wonks in the trenches who at least factually understand clinical delivery of care, but better than that, well, equal to that, understand analytics and what those things mean. So outcome measurements, outcome measurements, quality and cost. And I'm going to speed a little bit through this a little bit quicker because I want to leave some time for some questions at the end. Healthcare effectiveness data and information sets. These measurements and metrics are going to be needed to be further refined and expanded. So again, we're going to need to look at our outcomes. These things will not be static. And the next question is, how do we make it better? How do we improve the process? And for administrators, if you're like me, and for operators, the question for me has always been, what's the better widget out there that I can help implement for my providers that will enable them or empower them to deliver this care better, faster, higher quality? And oh, by the way, it's not just bolting something on that's going to add cost to the system. Is there an ROI? Can I prove efficacy of the thing and also, hey, it's going to pay for itself in 3 months? And those are keys, in my mind, for operators to help make those value arguments. And time-driven, activity-based cost accounting is considered the most accurate way of measuring true cost. And if you're not doing that right now, you're probably in the 99th percentile, because this is a lot of extra work. It's labor-intensive, and it's going to require folks on the operations side to wear one more additional hat. So refinement of the care process. Care process can only be improved via systematic data drive process improvement methodology. So using our data to manage where we are. CI programs, clinically integrated programs, need to understand their care process units, which I alluded to earlier. And you need almost real-time quality and cost outcome data, which, to my way of thinking, is still going to be quite a ways down the road. Employers and payers right now are searching for strategies to address the top 10% medical spend. So the result is a racing to operationalize value-based payments, and they're accelerating that look. So you can see from this little snippet, payers are starting to look at how they can ratchet down on this. Now, I don't know that payers necessarily have this in hand. I will tell you that in the late 90s, early 2000s, I had my docs lined up for the value argument that we were hitting at the time, our association's quality measures, and we were able to hit those consistently and sustain those, and that we delivered a lower cost product. And I went to a commercial payer to try to carve out, and they said to me they could not do that because they didn't have the mechanics in place to manage that. And that's fine. It is what it is. But now, fast forward today, and those things are coming down the road, and that's what we're going to have to expect. They are starting to get aligned with value-based delivery. So in summary, there's going to be a lot of moving parts. Much of this is still to be discovered between now and November. I think if you look at the complexity of what is entailed in the proposed rule and the number of comments that are out there, and I think just Google the, I don't know, MACRA MIPS, and just take a look and read a couple articles, just brief articles about the number of comments. But I think there's a storm brewing relative to this being rolled out. And a lot of it has to do with the smaller hospitals and the rural hospitals and those who don't have a lot of extra cash. And I know most systems don't, but those systems may be, argumentatively, may be a little harmed a little more deeply right out of the gate if this rolls out on the 1st. So my advice is to get started now and start looking at how we're delivering care, whether it's a single clinic or whether it's throughout an organization. And don't be afraid of the conversation. This has got to start, and I suggest to you we should roll this out and start looking at this and measuring, because the discussions are going to take a long time in and of themselves. But pragmatically speaking, how can this begin with the 2019 payment based on a 2-year look back to 2017, which I talked about? The status, time will tell on the rollout. MACRA MIPS, the question for me is it going to be like I-10 or meaningful use? And honestly, I would rather them roll out a fairly rock-solid product for the providers and the general healthcare community than roll out something in kind of a learn-as-we-go process. MIPS is the new SGR with a dual role as opposed to SGR, which is managing costs. This is a dual role of cost and revenue. I don't think this is all bluster. This is going to happen. It's just a question of time. And as I said earlier, as Medicare goes, so go many of the large commercial payers. There is going to be a following of the better mousetrap, I would suggest to you. And the quality carve-outs for me, again, on the commercial side is, can payers handle the quality carve-outs? I think some of them can, suggest to you some of them cannot. So with that, we've got some time for questions. Again, I would like to emphasize that the goal here was not for me to, at least in my mind, and if it was yours, I apologize, to really explain to you how a bundle payment is going to land in your lap and you're going to parse that out, because I think the dynamic is too fresh right this minute to understand how bundle payments across the board, and I know some places are able to handle them, but when we do these presentations, the question is, how do you address a broad swath of the audience with such a big topic? And so hope that you all got what you needed to out of this, and certainly would love for you to fill out the questionnaire, and please be as candid as you would like to be, because I do appreciate that kind of feedback. So questions and comments and thoughts? Okay, I did have a couple roll in. One of the questions was from a third-party billing company, or someone who deals with a third-party billing company. And they're contemplating what the new model might look like relative to third-party billing. And candidly, most of the IT piece of this, from my perspective, is really going to revolve around the IT infrastructure and the delivery of data. So it's going to be, again, health information exchange, how that information transacts back and forth, how we are managing PHI on the IT side, and to the best of my ability, as I see this right now, unless there's an issue with getting data out the door for the billing companies, my sense is that the billing going out is going to be fairly okay, if you will, but the billing coming back, if it's coming back in a lumped payment that needs to be spread out throughout systems, or a value-based reimbursement methodology, that might be a little trickier. And those are the things that are going to need to be defined, not on a global level in terms of nationwide, but in terms of what is going to suit the powers that be in whatever the network is. So as the old adage goes, healthcare is local, and so that decision will need to be made at whatever the integrated network and ride. But if it's an integrated network, I think that may make it a little messier in terms of how the dollars come back in. Another question I have is this is overly complicated, and I did touch on this a little bit. I think this must have rolled in during the conversation, but do I think it'll be delayed? So again, this is just Jeff talking to you. 30 years of watching what Medicare does, how things get deployed, in the most recent history of some of the ideas. I would suggest to you that it may be delayed. I know I would emphasize again that now is the time to begin moving forward and understanding how this will impact you in the day-to-day life of delivery of care. And I will tell you this too. I have to say, I think the management, one of the things, regardless of how you fall, which side you fall on the Affordable Care Act, I do think that one of the good things that's coming out of that is the management and the value of quality care. I really think that. If you don't like the other things, we could have a discussion about that. That's another discussion altogether. But I think that rewarding for clinical outcomes is not a bad thing. It just depends on who's defining what quality is, and that's where I would take a little bit of umbrage with the process. And so that is to say, why wouldn't we reward people for delivering consistent, good quality? But then the physician side, they'll say, well, this is not cookie cutter, and I totally understand that argument as well. Okay, and so another question again that this came in during the process was, or the presentation. This is big and ornery. How do we move forward? It's carving out time, and I know time is something none of us have, but it's going to require thoughtful contemplation about where you start. Who do you get involved? Just white paper. What are we going to do to start measure, and what will we measure? Which piece goes through the system, and how we can squeeze out cost and deliver the same results, which hopefully is quality as opposed to bad quality, obviously. And how are we going to do that? And don't be overwhelmed by the process. It will make it easier and more approachable if you pick a thing and you focus on that and you work with the physicians, the provider community. And again, none of this works without the docs. And the docs right now are in the mindset of fee-for-service, and fee-for-service is going to be around in some way, shape, or form. And what its dominance will be, I'm not sure anyone knows right now, but certainly there will be a fee-for-service aspect. But things are changing to value, and people need to get on board, and compensation plans and employed models are changing to value. We had a discussion this week with a large hospital-owned group out west, and they're really wondering how they're going to position themselves to reward physicians for value-based care and delivery of value-based care. So the kind of typical work RVU models are starting to morph and change as things move forward. So that's what I have for questions, and we are a little short of time, or short on time, so we have some time, so I'm going to give you 4 minutes back. But I would welcome any offline questions, comments, thoughts. I'd appreciate the relative bashing be kept to a minimum, but do truly, on a serious note, let me know how you feel about this. I can elaborate on things on a more candid individual basis, and I take a holistic approach to what I do. If you want to reach out on the side, just shoot me an email or a call and say, hey, Jeff, can we chat, and can I pick your brain? Totally happy to do that. Would love nothing more than just to chat for a little while about what's moving forward in healthcare and the dynamic. So I appreciate y'all's time today. I appreciate you sitting through the presentation. I hope truly that you got value out of it. And if you want to pick my brain further, please, by all means, give me a call back on my cell number, which I think is out there and available, or email me, and we can certainly catch up. Thank you so much for your time, and truly appreciate it.
Thank you, Jeff, for that presentation. Like you said, if you have additional questions, you can reach out to him directly. Again, we want these presentations to be beneficial to you, so please take a minute to provide your feedback. The slides to this presentation will be emailed to you tomorrow. Thank you again for joining us. Have a wonderful day.